From Penn State Health, this is Ask Us Anything About Colorectal Cancer. I'm Scott Gilbert. The second leading cause of cancer deaths in the U.S. is also often easy to catch early, even before it's cancer. Well, as March is National Colorectal Cancer Awareness Month, it's a good time to learn more about the risk factors and screening methods involved. In fact, there are some new guidelines we want to make you aware of, and here to talk about all of that is Dr. Hadassah Consuegra. She's a colorectal surgeon at Penn State Health Holy Spirit Medical Center. Dr. Consuegra, thank you. Great to have you with us today. What can we do to reduce our risk of getting colorectal cancer in the first place? Can you talk a bit about the connection with lifestyle?
Yeah, that's a huge, important aspect of preventing colorectal cancer, right? Obviously, we're going to get into screening, but what can we do to prevent it before it even becomes a cancer? So overall healthy lifestyle is the most important thing. When we talk about that, we're not just talking about activity, but also diet. So making sure you get your fresh fruits and veggies, your fiber, anything with fiber is super great for your colon. Avoiding those red meats, decreasing the consumption of alcohol, tobacco. All of those things are going to help decrease your overall lifetime risk of getting colorectal cancer. On top of that, those things are going to help you decrease your risk of obesity, but also adding in the physical activity to, again, stay active and help decrease those risks.
Yeah, so there are some of the factors we can control. On the other side of things, we've got things like family history, genetics, race. How important is it to screen these patients early, and what is the connection with those factors?
Yeah, so it's really important to screen those patients specifically on top of obviously our average risk patients. When it comes to family history, genetic history, race, we typically change the guidelines, which I'm sure we'll talk about later, in decreasing the age when we start screening patients, as well as increase the frequency with which we screen those patients.
You're watching Ask Us Anything About Colorectal Cancer from Penn State Health. Dr. Hadassah Consuegra, she's a colorectal surgeon at Penn State Health Holy Spirit Medical Center. She's here to answer my questions, but also your questions, and we hope that you'll add those to the comment field below this Facebook post. Even if you're watching this interview after the fact and not live, we can still get you some answers. And if you prefer not to ask your question publicly, you'd prefer for it to be anonymous, you can send it as a private message to the Milton S. Hershey Medical Center Facebook page, and we'll de-identify it when we ask it of Dr. Consuegra. So, one of the things that sets colorectal cancer apart from many other cancer types is the ability to catch it before it's cancer. That would seem to suggest that screening is everything, isn't it?
Screening is the absolute most important thing. No matter how healthy you are, which obviously we continue to emphasize, screening is the best, most proactive way to take care of your health and be on top of that so that you can prevent this, right?
So who should be screened and when? I mean, this is an important question because your answer to this is going to be different than it might have been a year or two ago. Guidelines have changed, right?
Yeah, so for years now, there's been a specific group of patients that we've screened at a younger age, specifically African Americans. We recommended screening at the age of 45. In the last several years, the American Cancer Society has actually changed the recommendations from 50 to actually 45 as well for all patients. I should say all patients of average risk. Again, starting at age 45 is going to help catch those cancers even sooner, as the incidence of cancer in patients younger and younger are being diagnosed more frequently.
And you mentioned race. What about family history? Probably another factor that involves an earlier screening, right?
Absolutely. So when we talk about screening, we kind of lump patients into average risk and then high risk patients. So high risk patients definitely get screened at different intervals as well as younger age. So when we talk about specifically family history, we're actually recommending to screen patients starting at the age of 40 or 10 years before the youngest family member was diagnosed. And we talk about family members, we're specifically talking about first degree relatives. So mother, father, brother, sister, those patients.
And as you note, as the guidelines for screening become younger, it's because we're seeing more incidents, a rising incidence in younger people. Do we know why that's the case?
We don't know exactly. We want to obviously attribute it to a lot of the first risk factors that we talked about earlier. Again, those healthy lifestyle and whatnot. We are kind of attributing it to that. However, I think there's a lot of risk factors that we haven't yet established yet. So there's still a lot more research to be done. overall, the most important thing is, because we are seeing it, we definitely want to make sure that primary care physicians are aware of that, and patients, so that, again, advocate for yourself to get a screening that much sooner.
And we'll talk about the various types of screening shortly, but once somebody is screened, how often will they need subsequent screenings after that? Is it frequent?
So it's actually not that frequent, depending on what we find during your colonoscopy. So it's every 10 years for an average risk patient. Again, that really is variable for each patient. So if we find a polyp, or we find numerous polyps, or depending on the pathology of those polyps, that can definitely change your frequency. And actually, we would suggest, again, maybe a little bit sooner rather than the 10 years. So it's actually not that frequent, again, depending on what we find. So it's very individual basis.
And speaking of those screening methods, let's get into those now. We often hear about colonoscopy. That's the gold standard, isn't it?
Absolutely. Colonoscopy is hands down the best test that you can do for this. The reason being is, and I'm sure we'll talk about that in a second, is this test allows us to not only see what we need to look for, but it allows us to intervene, right? So when we do the colonoscopy, we're able to insert the colonoscopy through the anus and work all the way around to the beginning of the colon on the right side, and even see the distal part of the small bowel. By doing that, again, we're looking for any abnormalities, including polyps. And during this procedure, we're actually able to take care of that. That means we can either take a bite of it and send it to pathology, or we can even hopefully remove it completely, and you won't have that polyp anymore.
Yeah, and talk a bit more about what a polyp is, if you could, because it's not always cancer, right? In fact, it often isn't.
Absolutely. And that's the key, again, with screening, is that these polyps are just a colon tissue that has kind of multiplied and created this various types of polyps. It can be one that looks kind of like a lump. It can be flat. But by removing these polyps before they become cancer, we're again preventing a patient from having cancer down the road. And that's the key, is that once we are removing these polyps, we're able to look at the specific types of polyps to determine, is this one that's more high risk that we maybe need to change the frequency, so that, again, we're intervening before something happens.
This is Ask Us Anything About Colorectal Cancer from Penn State Health. We're talking today with Dr. Hadassah Consuegra. She's a colorectal surgeon at Penn State Health Holy Spirit Medical Center in Camp Hill. We welcome your questions for her, so add those to the comment field here, or you can send them, if you prefer, as a private message to our Facebook page, and we'll de-identify them before we ask them. So we're talking about colonoscopy here, and some people might say, yeah, I get that it's the best, but ooh, that prep. They fear that prep. What's your advice for them on kind of weathering that stage of things?
The prep, I will say, is everyone's big complaint. The colonoscopy is the breeze in the park. You get a really nice nap. You're not having to deal with that part. The prep is the hardest part for people to deal with. That being said, the preps that we do nowadays are so much better than the preps we used to do several years ago. There's so many different alternatives. Each physician is going to have their own preference on the specific type of bowel prep we use. But if you stick through it, it's a day, it can change your life. So I would say just stick with it, and it's worth it.
Right. Beats the alternative, right?
Absolutely.
So we talked about colonoscopy. I've also heard of sigmoidoscopy. What exactly is that, and how does it compare?
Yeah. So a colonoscope is a long, flexible tube, right, that we're able to snake through the colon. The flexible sigmoidoscope is similar to it in that it's just a little bit shorter. So while it gives us the same view, it only actually shows us about half of the colon. The benefit of it is, again, it's a little bit shorter procedure, but really, honestly, you still kind of have to go through the bowel prep, and you're not able to visualize the whole colon. So to me, obviously, again, that kind of emphasizes why the colonoscope or colonoscopy is the gold standard.
And if you're going to go through the bowel prep, you might as well get the colonoscopy.
Yeah,
it sounds
absolutely.
like, because it's more thorough. It inspects more of
Absolutely
everything that's down there.
Yeah,
Okay,
there's
great.
a chance of missing tumors on the right side of your body. So
What about stool DNA tests? We see these advertised, things like Cologuard. How do they stack up compared to the other methods?
yeah, the benefit with the Cologuard test is that you kind of get to do it from the comfort of your own home, right? You don't have to do the bowel prep. You don't have to go in, have a procedure. That being said, it definitely, you have to weigh the pros and cons, right? So what it does is it specifically looks for DNA in your stool that is correlating with, again, colon cancers or large polyps. And again, it looks for that DNA within the stool. If it finds DNA in the stool that's consistent with a cancer or a polyp, it only kind of gives us a yes or no answer, if you will. So regardless, you still have to undergo a colonoscopy then once it says it is positive for us to be able to actually locate, is there a tumor, is there a polyp, can we take care of it via a colonoscopy? The other kind of downside with that is there are some false positives and false negatives, right? So there's a chance that we could miss something, and there's a chance that you have a positive and you undergo a colonoscopy anyways, and you may not find anything. So it's definitely important to, again, have a conversation with your primary care physician about this. The other downside is not everyone can do it, right? So there are certain contraindications or patients that may not qualify for a Cologuard. Specifically, we're talking about patients who have a family history of colon cancer. They have a genetic or familial disease related to colon cancer. They themselves have had colon cancer, or they have polyps in the past, or if they have rectal bleeding. So that would not allow you to have the Cologuard.
We've talked quite a bit about the familial connection, and Kathy has a question related to that here. She's asking, my maternal grandfather has colon cancer. My mom passed away at 62 from colon cancer. Kathy, we're sorry to hear that. My uncle, she says, her brother had cancerous polyps removed. She said she had her first colonoscopy at 40 and it was clean, but she says, I have to go every 5 years. Would I be considered high risk? And should I go earlier or more frequently than every 5 years?
That's a great question. So you are considered high risk in the sense of your family history. That being said, in a high-risk patient, as long as their colonoscopy is clear, we do recommend every 5 years. So that can change. You know, if your colonoscopy showed something, we may decrease that or increase the frequency, so have you come back sooner. But if your colonoscopy was clear during your first one, then you can go ahead and wait the 5 years. Obviously, I always emphasize to my patients, if you notice a change in your bowel movements or any blood in your stool or anything like that, that would be important to let your physician know sooner so that you're not waiting the 5 years.
Thank you, Kathy. Great question. And we welcome all of your questions for Dr. Consuegra. Just add them in the comment field below this Facebook post. Our next question comes from Daniel. Daniel's saying he had a colonectomy about 5 years ago. Should I be concerned about recurrence?
So when we talk about colectomy, again, it would be important to know specifically why you had the colectomy, what type of tumor you had, how invasive or aggressive it was. But typically when we talk about cancer surveillance or, again, monitoring patients after they've already had a history of colon cancer, we typically follow them out several years. A lot of times, again, 5 years, even sometimes farther, depending on the type of tumor again. So that would be a conversation with your family physician or your surgeon that did your surgery, that they can review all of that and make sure that you're continuing on the surveillance pathway. Yeah,
and it seems like some of these questions point to the fact that there are some very unique, everybody's got a unique situation, right?
Absolutely.
And so it's really hard to give advice that really applies to everybody. But, you know, I think these are really great questions that point to just how everybody's coming at this with different risk factors and different circumstances.
Absolutely.
We welcome your questions for Dr. Consuegra. Drop them in the comment field below this Facebook post. And again, you're welcome to send them as a private message to our Facebook page if you prefer to ask your question anonymously. So I was wondering about symptoms. Let's say somebody hasn't gotten a screening, or are there some concerning symptoms people should watch for? Does it typically present in the same way in everybody or not so much?
That's an important question to ask, and even more important to emphasize why we talk about screening, right? So probably the most common symptom is no symptom, which is why we try to do screening so we can catch them before patients do have symptoms, right? When we talk about symptoms that patients do have, though, some of the questions we ask are if you've noticed blood in your stools, if you've had a change in your bowel movement. So not only the consistency, but also, the size, the quality. Sometimes you can have bright red blood versus, even darker stools. Abdominal pain, which can be vague, but again, something to keep in mind. abdominal bloating or distension, weight loss. Those are kind of some of the more common but also vague symptoms. When we talk about it getting farther along, they usually become more symptomatic. So as the tumor progresses, as it becomes larger, patients can actually have bowel blockages, or when the tumor gets so big that it won't allow stool to pass. And that's obviously a much more concerning symptom. Sometimes it can get so big that it actually pokes a hole in the colon wall or has a perforation, if you will. So it's super important, again, to emphasize even more the importance of screening to catch it before you do become symptomatic.
All right, we have a comment now from Arletta. She's just sharing some of her experience. She says she did the home DNA test for 3 years. The last one was flagged. Colonoscopy found stage 3A cancer. Surgery and 6 months of chemo, but it's almost a year now since the last chemo treatment. Colonoscopy in the fall found polyps, but they were non-cancerous. Agree, colonoscopies are easy. The prep is the worst part. So, here's a real success story of somebody who went through, she did the home DNA test, it got flagged, and then she followed up, which seems like a very key step here.
Absolutely. And I think something to also pay attention to is that she's had 3 tests, right? And it wasn't till the 3rd one that it became positive. So it's important to also realize that each test has its fallibility. So we want to make sure, and again, emphasize the importance of colonoscopies, because the false negative rate is much lower than a Cologuard test, because you're able to, again, visualize something. But that's great. That's an awesome success story.
In addition to her comment, Arletta has a question, and that is, for your opinion on the age to first get a colonoscopy. Do you feel that 50 is too old? I see a number of cancer patients in my support group who are in their 30s or younger. And I know, Dr. Consuegra, you did talk about how those guidelines have dropped a little bit, but 30 sounds really young for colon cancer.
Absolutely. In those patients, you always have to question whether there's some type of genetic or familial trait in the younger population. But absolutely, we do see patients who are even younger than 45. But again, typically there's not always, but often some other underlying process that's happening as well. So I do think 50 is too old. Hence, I would definitely emphasize, again, screening at age 45, unless you definitely have one of those family histories or disorders that would preclude you from getting it that late.
As I mentioned, it's National Colorectal Cancer Awareness Month. We use that term, but in fact, the term colorectal cancer lumps together 2 different types of cancer, colon cancer and rectal cancer. And when it comes to treatment, each is managed differently. Can you walk us through that a bit?
Yeah, so the first step in diagnosis and management and treatment is obviously getting a piece of that specimen for pathology to say you do or you don't have cancer. Once you do that, then you start working up the patient. And in that sense, colon and rectal cancer is the same type of similar start of the workup, right? So when we first diagnose someone, we go ahead and stage them. When we talk about staging, we're not only looking at the tumor itself, but we're also looking to make sure, has it spread elsewhere? So the first thing we do is look for spread elsewhere, and we order CT scans of not only the abdomen, but as well as the chest, because that's the most common places for colon cancer to spread. And again, that's the same thing for rectal. Once again, we decide, okay, there's no spread elsewhere, then we have to determine whether we go ahead with surgery or, again, an alternative like chemotherapy. Most often, we attempt surgery in these patients as long as they're not spread elsewhere. There's other factors that we look at, like local spread of the disease, as far as, is it a real bulky tumor? Has it invaded other organs? Sometimes in those situations, we're talking about chemotherapy first to try to hopefully decrease the size of the tumor before undergoing surgery. But all of that, again, as you've said before, is kind of on a patient basis. As far as rectal cancer, I know we mentioned the CT scans. One of the things we do in addition to the CT scans is actually an MRI. The nice thing about the MRI is it actually allows us to see how much has the tumor invaded locally in the pelvis, and is there any lymph nodes that have been involved. More often than not, rectal cancer is treated first with chemotherapy and actually radiation as well. And then, depending on how that goes, we talk about surgery. So it's very important to kind of distinguish them.
And chemotherapy and radiation, again, used not as a curative necessarily, but rather to shrink it, make it more manageable so a surgeon can then handle it?
There is some literature to suggest that sometimes chemotherapy and radiation alone can be curative, obviously with close observation, but oftentimes, yes, it does lead to surgical resection.
As a physician, I have to ask, do you see a disconnect between the fact that colorectal cancer can be detected in the precancerous stage? Right here, we talked about polyps, yet it's also the second leading cause of cancer deaths. I mean, I don't want to put words in your mouth, but that must frustrate you to some extent.
It does. And I think the big problem is people are just so hesitant to do it, right? You got to have somebody that's kind of in your court and pushing you in a way sometimes. Everyone hears just the horror stories of bowel preps and whatnot, or they know someone that had a bad experience. And I think it's just so important to continue to emphasize that you got to get screened early. But you're right. It is frustrating that we're waiting till these tumors become bigger. We can catch this sooner, and we can treat people before it even becomes a problem. So it goes back to just emphasizing screening, screening, screening.
Yeah, indeed. And I know we'll add some information in the comment field of this Facebook post so you can learn how you can get in touch with Dr. Consuegra and her office. But I want to thank you very much for taking the time today to talk with us, Dr. Consuegra. And there are a lot of folks here who on the feed who I think have found this to be useful, including we want to thank Joyce for her kind comment here. She says, thank you, Dr. Consuegra, for all your useful and important information. And it has been just that. So I appreciate that. And also some really great questions from Joyce, from Arletta, from others, from Daniel, Kathy. So thank you for the great questions. Thank you for watching. Ask Us Anything About Colorectal Cancer from Penn State Health.